Clint, you want to get started?
Sure. Speaking of trading places, I don't know who would want to trade places with Dr. Jain right now, but I will say you're doing a fantastic job. I haven't been talking to you as much as we spoke in the beginning, but from the periphery, I know you guys and the folks from the health department and the city and county are in the trenches doing the best work that you can do. And at least from a state standpoint, I see those numbers every day. I think Memphis looks good in comparison to other parts of our state. And that's not really something to be celebrated, but it is a testament to the hard work you guys are doing. For those that I've not spoken with on previous calls, my name is Clint Cummins. I'm the CEO of the Memphis Medical Society. Always happy to facilitate a conversation with Dr. Jain and some of our members and friends out there in the community. This will be recorded. So Allison, I'm prompting you now to hit the record button if you haven't already hit it. And Dr. Jain's going to talk to us tonight about the latest in testing with some specifics on assurance testing. And I think we have a couple of guests tonight, Dr. David Smalley from AEL Laboratories, as well as, I didn't see Jim Sweeney on the participant list, Dr. Jain, so he might be under another persona on here, but Jim Sweeney with Popular Healthcare may be joining us as well. And I know this will be great information to share with folks who might need to do that type of testing. So Dr. Jain, I'll turn it over to you.
Great. Well, thanks, Clint, and thanks to the Medical Society. And you can see my screen?
Yes.
Okay, great. I won't take a lot of time. I'm not going to repeat all the things you've heard before either. This is all new material for the large part. And what I want to do is to introduce you to a new strategy, new way of thinking of how we can combat the virus beyond the usual, the masking, the distancing, and the hand washing. All right, so it's the concept of assurance testing and pod-based testing. Let me give you a little bit of a background. We are facing a lot of challenges, but the greatest challenge that we face, I think in large part you'll agree, is how do we keep and open our businesses? And how do we open them, some of them, and how do we keep them open? Restaurant, retail stores, offices, how do we prevent an outbreak? And more so, how to stop a community transmission which goes haywire, and that we have to end up having to do a lockdown that we did in March, and not to have to do that. As you know, places in Europe have had to do that again. We do not want to go there. What are ways that we can prevent? And then that, as well as how do we open up our schools? I think those are some key questions that I want to try to address this evening with the idea of what new tool that we can deploy. A little bit of a background of where we are with this pandemic in Shelby County. All right, so these are cases per 100,000. This is what everyone nationally is following. We were doing really well when we had the lockdown. We opened up and we went from what was 5 to 7 cases per 100,000. And then, as you remember, we had a very difficult July. We were had to reclose our bars, and then we did put a masking mandate. And then we did well the numbers came down, and we have reopened. And what you see is there has been a climb again. Where and how far this fall wave will go, we don't know, but we are certainly in a climb that can be very problematic. And this is the daily number of cases that we follow each day at the task force. The hospitalization numbers, we've done really well, but over the past several weeks, we're seeing again a rise up to 200 a day. We have lots of hospital patients, ICU patients with COVID, and also in the ICUs, we're also seeing that rise. How far or long that will go, we don't know, but what we know is this: by doing what we're doing now is not going to be sufficient. We have to add something new or different. And we don't want to do a lockdown again to the extent that it was done. So what is a strategy to contain COVID? The first, which was the safer at home, the lockdown, yes, we've gone through that. Second is testing. Third is vaccinating. Once we get the vaccine, yes, that will make a huge difference. But let's talk a little bit about testing and what are different ways we can do it. This is all in addition to the masking and the distancing that we're doing. We can be doing testing of those who are symptomatic, but what assurance testing really talks about is doing testing of asymptomatic individuals, our school children, our workforce. We're right now at doing about 3,000 tests a day. I'm talking about a logarithmic greater. I'm talking about 30,000 tests a day. And that's a way to make our places safer. So what is assurance testing? What is this concept for our city? What could it potentially look like? First, it's large scale, large numbers, right? Going from 3,000 tests per day to 30,000 tests a day. And it's low cost. So right now, a COVID test costs $100. We're talking about markedly reduced cost of the test, tenfold decline. And what I'll have is some of the laboratory directors are here and they're going to talk about that as well. We're talking about regular testing. So assurance testing means that we just don't do a one-off, but we do it on regular weekly intervals so that we know if a virus is penetrated in our workforce, in your clinic, or in a school. It has to be convenient, right? So if it's not convenient, people aren't going to be able to do it. And it has to be non-invasive. So none of that deep nasal pharyngeal swab that's like a brain biopsy, but more a do-it-yourself kit that's a nasal swab, which is very simple to do. And it's doing it for the asymptomatic individuals, people who are not having symptoms. So in short, this is what the definition of assurance testing is. And this is where I believe we can make a fundamental difference in our city in containing this. No other city has been taking this aggressive of an approach that we are in testing. However, there are other places who are working on these ideas. Mayor Strickland and I and a team of individuals have been working on this for the past 4 months. The lab directors have been phenomenal in their efforts with this. Back in April, we started meeting. In May, we shared the vision with the mayor. We started doing a technique called pooling. I'll talk a little bit about that. A lot of the labs, including Popular Healthcare, AEL, had an EUA, the emergency use authorization. And then we started working with the cities and the city employees and others. And we've also had another technique called pod testing. So before I go into the techniques and tell you about what is there and what your clinic can potentially do in utilizing this at the low cost, would be first to go over the numbers. Our positivity rate, which tells us how many individuals are coming in, is still high, and they get tested, and what percentage of them are positive. We're still very high at about over 10 to 12%. That was for individuals, and this is for the number of tests. So those are for individuals who have been first time getting tested, but people are getting tested repeatedly. There are a number of tests that are being done multiple times, and those are for asymptomatic, and that positivity rate is lower at about 5.3%. The number of specimens we're collecting for symptomatics are generally in the range of about 1,000 per day. But if we add the asymptomatics, we're at 3,000. So give you an example. What does St. Jude do to keep their employees safe? What they do is something called assurance testing, asymptomatic testing. Every employee gets tested twice a week. And they have found multiple employees who have had no symptoms, and then they were obviously positive with the COVID PCR test, and then they were able to take them out of the workforce so they wouldn't infect the children and others. And so what I'm saying is that there are multiple folks who are already doing the asymptomatic testing. And now what we're talking about is expanding that for 3,000 tests a day to a logarithmic more. I share an example of universities who are doing this. My son goes to Georgia Tech. They started doing assurance testing. They have 20,000 kids on campus. They started doing 2,000 tests a day, and now up to 10,000 a week. And what they were able to do is stop any outbreak. And so what I'm sharing with you is real live examples of why and how universities have been able to stay open. And what we want to do is the same thing for our schools, but also our workplaces and others. So what has Memphis done and where do we need to go? We have done a tremendous amount of innovative work, pooling 7-to-1, pooling 20-to-1, and got an FDA clearance to do that. We've also done something called pod-based pooling. I'll explain that. And we're developing what we call do-it-yourself kits. So what do I mean by pooling? The thing about the PCR test is the following. It is exquisitely sensitive. And so if you put 5 samples in one tube and they're negative, that means all of them are negative. And so when you have a low positivity rate, you don't need to do individual samples. You can just put 5 in there. If something turns positive, then you take that and then you do that in more detail. We've been written up in both New York Times and the Wall Street Journal about the work that we've been doing here. And now here's the menu of testing that's been available, and talk a little bit also about the pod-based testing. What pod-based testing is, and I'll go back to the other slide, is the following. Instead of doing 20 samples at once, instead of doing 20 samples and taking them individually from the school or workplace to the lab and then pooling them, what pod-based testing is, you take one tube and 20 individuals, put each one goes in, takes a nasal swab and puts it in one tube. And what that does is you only have to send one tube to the lab. You have a unit, which is a pod, and that pod is what is able to be then tested. If it's negative, then everyone is negative. If it's positive, then there might be one individual in there who would be positive, and they would have to get retested. So the menu of tests that we have available, the standard test, which is the 1-to-1, which FDA approved, it doesn't do any pooling, and we do no repeat swab is required. Any prevalence can be there, and the turnaround time is less than 24 hours, and the cost is about $100. Then there's individual swab PCR. There we could do pooling if the positivity rate is low, between 1-to-5 to 1-to-20. And then even in those individuals, there is no repeat swab that is required. The positivity rate needs to be between 0.5 to 5%. Turnaround time is very good with our labs, and the cost is reduced on that. And then there is pod-based, which is surveillance type testing. And we can put 20 swabs in one test tube. If something is positive, then you do have to get tested again. This is very good when the prevalence rate is low. The turnaround time for the first test is 24 hours, and then another 24 for the second one. And then we're talking, significant reduction in price. And some of the labs will talk about how they're able to manage that. So what we're talking about is, if your clinic is interested in having the folks, your staff be tested at regular intervals, which I would recommend, This is a great strategy to use. In our clinic, what are we doing? We're doing pod-based testing. Every week, we have a tube. Everyone swabs their nose, puts the swab into the tube, and then at the end of the day, we send the tube over to the lab over at Poplar Healthcare in this case. And then by the next morning, we know if it's been positive, if there was a positive, or it's everyone is negative. If it comes back negative, then everyone's negative. Positive, then we have to re-swab those in the pod. Now, the question is, how good is this data on swab testing for a pool? Now, I know these are a lot of numbers and you're probably not interested in knowing all that, but what the way you measure how good a test is certainly by its sensitivity and specificity, and more so by looking at how well the 20-to-1 worked with the 1-to-1. And this is some of the data from Poplar Healthcare. 19 out of 20 samples were picked up when we went from 1-to-1 pooling to 20-to-1 pooling. So 19 out of 20. Similar data out of AEL. The only ones that get lost are the ones which have what we call a high CT value. Now, CT is called cycle time. When you have a cycle time above 30, you're in the tail end of an infection. You're really not very, if at all, infectious. People have argued that the FDA has set the threshold very high at 40 being where is a positivity rate, anything below 40. People say it should be more around 30. What we do know is that anyone below 30 is infectious, anyone above 30 is not infectious. And in this case, the pool testing loses some who are in the mid 30s. It captures a lot of them that are in the low 30s. So pod-based assurance testing. So we're talking about how that can be used. The key variable, again, is going to be the positivity rate. The positivity rate has to be below 1% up to about 0.5% for it to work really well. And I'm going to have Jim Sweeney from Poplar Healthcare talk a little bit about both the positivity rate and also the price points. How often do we do the testing? That's a challenge that we haven't answered that question, even other places across the country. What we're saying, maybe every week, maybe once every other week. St. Jude decides to do it twice a week. Ideally, it will depend on how frequently, it will depend on the positivity rate at the beginning and also the affordability of the test and the level of concern that you have in trying to pick up a case in the asymptomatic arena. So maybe I will pause here. And Jim Sweeney, if you want to unmute and say a few words, and then I'm going to go into how this can be potentially operationalized. Jim, can you hear me?
Yeah, I can hear you, and thank you for the opportunity to talk this evening. I'll just make a couple of comments. Obviously, you saw the journey we've been on the last couple of months. We've been actively pooling a number of different categories of patients, and basically the way we've handled this is we've started off pooling people, populations of less than 5%. We look at each client individually, and then we work them into 1 to 10 or 1 to 20. So we do a lot of work with GI groups around the United States, and they're doing a lot of pre-elective screenings. And we now have probably a third of our GI groups at 1 to 20 pooling because we're monitoring on a day-to-day basis that prevalence. When we're talking about the pod testing that Dr. Jain is talking about this evening, we're really striving for a population with a prevalence or positivity rate of less than 0.25. And as you can see from the data that we feel quite confident we'll be able to pick it up. And the price point on the pod, talking with Dr. Smalley at AEL, we feel collectively, because we're going to try to keep this uniform in the community, that tube with up to 20 swabs, we can offer it for $100. So it's basically getting the cost down to about $5 per person that's in the tube. So it's a very low cost, efficient way to help provide assurance testing. And then, as Dr. Jain pointed out, if that pod is positive, then they'll be directed to isolate, go get a follow-up test within a certain amount of time, and then individually run. And that test could be billed to someone's insurance because it's a possible exposure. So those are some additional comments and thoughts. Dr. Jain, I know you want to go through and show the illustration of the material that's included in the kit, but we're trying to make this very simple and straightforward. Okay.
Sure. So the concept is that we want to be able to do, again, large, high volume, low cost, but it has to be easily done. And so a do-it-yourself kit could be provided by the labs, and what it would contain would be in large part the instructions, lab form, but here is the conical tube with the media that would be there. There would be 20 swabs available, and the group does their swabbing, each individual puts a swab in, and then someone drops it off, or someone gets picked up, someone picks up that, and we know the results within 24 hours. And so convenience is a major factor. It's really the whole idea of scaling up. And imagine you go to a restaurant, and outside that restaurant, you see a sign that all employees have been tested this week. It allows the folks who are coming in to be assured that at some point, the employees were tested. And so that idea of assurance is brought to the retail store or to the restaurant. Same thing we want to be doing at your clinics as well. Provide that sense of assurance is there. How and what timelines could we potentially scale up? Just sort of thinking out loud, try to begin to distribute kits. And David Smalley is also on the line. David is the lab director over at AEL. And David, if you want to unmute and talk a little bit about what you have been doing with the pool testing and also pod-based testing. Are you there? Yes.
Okay, can you hear me now?
Yes, we can hear you.
Okay, like Jim was talking about, AEL has been very aggressively looking at pooling. We took the process with the pod testing very seriously, because one of the things that we've always been concerned about since we're in the testing is the cost of this. These tests are not cheap with this RNA detection process with PCRs. And unfortunately, there are some tests out here that seem to imply that you can do a 3-minute test and get the data. And that's just not true. They're not effective. So what we looked at is, from a very strong scientific standpoint, of how could we actually move towards testing high volumes. And anyway, we collectively worked with Dr. Jain and Jim, and the dilution process, it sounds a little bit quirky when you think in terms of 20 tests at one time, but I can assure you that the data is very, very clean. The sensitivities are quite good. And the fact is that since these are not linear tests, the way that the actual testing works, the dilution process works very, very well. So as you saw with the kit types of things, what we would end up doing is working with individual businesses, clinics, and so forth, and be able to provide those define who is in those pods so that that information is directed back to the healthcare provider as quickly as possible so that they can quarantine and then do follow-up testing. So we're very excited about this. I think this really gives us an opportunity to really get our hands around this pandemic.
So the question comes up is, will Memphians go for this? Certainly the doctor's offices and others will see the value. And we did a survey just 2 weeks ago, and we asked this question, and the answer was 60% of Memphians are willing to be tested. And it was, would you be willing to be tested if you had no symptoms? And 60% said yes. And 34% were willing to pay $10 a test. So you can see that that's phenomenal, in my opinion, a phenomenal positive response from the community. The fact that even we can get a third of the population to pay and get tested regularly, you know, you really don't need 100% of the people to be tested regularly in order to bring this epidemic down. You bring that row knot down and you can move towards a, you know, 1 or 2 per 100,000 rate very quickly, because it's just like a slide. Once you're on a downward curve and one person is not infecting more than one person, over time, you will have less and less people that come. So we have the willingness in our community to be tested regularly, as well as to pay for the test. How do we and who do we engage to scale up assurance testing? Certainly the schools and the charter schools and private schools are already doing it. And if you're a parent, please encourage your school to do it. The city is really helping out. Shelby County schools have also said that when they open up in January, they are going to have some element of testing. Restaurants can do it, bars, retail stores, doctors' offices, certainly there. The city's doing it, the county and others are really looking into it. And so those are real opportunities for us to take advantage. If you are interested, there are 2 labs here. You've heard from both of them, Poplar Healthcare and AEL. They are available to help in learning how you can utilize pool testing for your clinic. I will pause there. I know there's a lot of questions. There's we haven't talked about the antigen test. We haven't talked about lots of other questions, but I'm more than happy to answer them. But I want to be very mindful of your time and answer questions which are very relevant to you and your practice and how we make our city safer, which is critical, using a something other than the usual that we've talked about.
There's a couple in the chat box, Dr. Jain. One is one I typed in actually are the city and the county and the health department, are they going to be pushing this, and how so?
Great question. And so I just wrote up this morning, Dr. Haushalter, myself, and Dr. McCullers, a guidance document, and which will become possibly part of a health directive, but that we will highly recommend. We will highly recommend that assurance testing be done for schools, for universities, for bars and restaurants, for medical clinics and others. So that's where it will be highly recommended. So there will be Dr. McCullers, Dr. Haushalter, myself are all on the same page about the use of assurance testing. Great question.
Another question was, do you recommend the same PPE for testing symptomatic and asymptomatic patients?
No. So this is only for asymptomatic testing. And in fact, you really don't need PPE for this. What you have is individuals are self-swabbing. So this is really important to talk about. Administration of this is not the deep nasopharyngeal. It's not even the mid-turbinate. It's an simple anterior nary swab. You have a test tube, which is put, people come in, and we put it in one of the clinic rooms. Our office staff comes in, they open up a Q-tip, They swab their nose, they put it into the test tube, and then they leave. No one is needed to be in a PPE for this.
There was a question about speaking to any of the updated medications. I know actually UT put something out today that some of their researchers had some success with some medications. Can you speak to any of that?
I don't know which ones, but I can tell you that we are, in terms of management and treatment, using steroids. So that's clearly been shown to be very beneficial, dexamethasone. And then also we're using remdesivir. We had been using plasma, it hasn't been that successful. We've been using tocilizumab, one of the IL-6 inhibitors. Unclear how beneficial that is either. But we are quite hopeful for two things. One, new medications coming down the pike, as well as the vaccine. But understand this, even if the vaccine comes as early as November, December, it's available to us as doctors. It will be available to the elderly, but really will not be available for the general public. And imagine all the school children. There hasn't been a clinical trial done on children yet. So we've got a long ways to go with this epidemic. And we have to make our workplaces safer. We have to make our schools safer. And this is a science-based solution, which goes beyond than just the usual behavioral changes. And I will say this, the most powerful behavior change is someone hearing that they are COVID positive or a friend or a relative is COVID positive. If that doesn't change your behavior, I don't know what does. But that is why testing is so important. And if enough of us do this and bring the rho naught below 1, that's when and how the epidemic will end, and at a local level. And this is all a local phenomena. And taking care of the epidemic is a local phenomena. Yes, we may have seeding from outside, but it's a local phenomena that we need to deal with.
And just to clarify, so the process is contact either Poplar or AEL, figure out the logistics of getting those testing kits, and then go from there. I mean, it sounds pretty simple, but I just want to clarify for the recording.
Yep, absolutely. We're doing it from our office. We're encouraging other offices to do it, restaurants, retail stores. We're going to be encouraging them to also do it. Yeah, we've done the science to make sure that this is doable. 2 labs have verified this independently. So we feel very confident about the process. Logistics can be difficult, but you're all a medical facility. Doing a swab is a no-brainer.
There's a follow-up question for discussing the evidence that testing once per week will work. Seems that it would need to be more frequent as St. Jude, what St. Jude's doing seems to have an impact.
So you're right. We don't have clear evidence that once a week is sufficient. Maybe we need to do it twice a week or possibly more often. What we do know is that when we look at universities and colleges, I gave you an example of Georgia Tech, 50% of the student population was getting tested once a week. Some of the data that's coming out of New York City, and when they're opening their schools up, they're thinking maybe 20 to 20% every other week. Honestly, we're going to have to build it, as we're trying to fly this thing. I have no right answer on this, but not taking action is not the right answer.
That's all the questions I'm seeing right now. I'll let you know if others get interjected.
Okay, I know some of the folks I've chatted with, and I know Fred is on there too. Fred, maybe your thoughts or comments. You and I chatted about how at your clinic you face the challenges of having folks being tested and so forth. Maybe if you want to unmute and give your thoughts.
Yeah, so we have 2 ambulatory surgery centers and 5 offices. So we over 650 people involved, including our residents and our trainees. So we've been waiting and looking for something like this where we could really step up the testing on a larger scale. So I'm excited to hear about this development.
Okay.
And we're very interested in participating.
Great. So yeah, I think Campbell's Clinic, you're leading a clinic in the Memphis area, and participation in a program like this would both be beneficial to you and to see for other medical folks to see how they can do it as well. So I think that this is the way to move ahead to make our healthcare settings as safe as possible, as well as make our retail and restaurant settings as safe as possible. We really need a new strategy until the vaccine comes here.
Another follow-up question, Dr. Jain, about the turnaround time on these tests.
Good. Absolutely, great question. We are very comfortable, and I'll have Jim Sweeney and Dave Smalley talk about that too, that we have a turnaround time that's well within 24 hours. But Jim Sweeney, do you want to answer that?
Yes, Dr. Jain. No, as you're indicating, I mean, right now with the capacity that both AEL and Poplar have, we've got tremendous bandwidth. Over the last couple of months since July, we've added several new instruments. We've been able to secure better supplies of reagents and consumables. So right now, the capacity that Poplar has, I can run close to 4,500 individual tests. And if I was to pool variations of that 4,500, we could do ourselves close to 20 to 22,000 tests a day.
Yeah. David, do you want to address the turnaround time?
Jim summed it up. What
Okay.
we did in July, we had a very rough time on some of the reagents availability and so forth, and the amount of testing being done. Since then, as Jim indicated, we've added additional equipment, we've added additional capabilities, and our turnaround times are exceptional at this point. We have the capacity actually at AEL to do somewhere around 13,000 tests a day. And again, with a pod type of thing, 30, 40,000 a day is really not a challenge. So I expect exceptional turnaround times. And I think the other thing that we want to do is, as we do that initial pod testing, then that becomes a priority to notify the provider that we have a pod that's positive, and we do follow up as quickly as we can so that quarantine is as limited as possible.
Great. And what I would also say is that there are many parents here on the phone. Really encourage your schools to be looking at this if they're not already doing it. St. Mary's been doing that, and they've been extremely successful in being able to open. I've recommended this for athletic sports, contact sports. If you want your contact sports to continue safely, you've got to test the students, the athletes regularly, more than once a week, because there are the chance of them spreading to all others is very significant. Other questions or comments?
Dr. Jain, is there an ideal scenario? You brought up sports, and that will definitely get brought up in this discussion. and being a parent, my kids are in sports as well. Is there, if the kid plays on a Saturday, what's the ideal scenario? They get tested Thursday evening or Thursday afternoon?
So I think this really speaks to the whole idea of the laboratory has to partner with the school or the institution, and they have to have a clear conversation on both the logistics, what is the outcome that they're looking for, right? If they're looking for a safety level that is at a St. Jude level, safety level, then that's a very different conversation than to say, okay, we're looking for a safety level, which is at, someone who's, flying and may get the flu or not the flu type of safety level. And then also the price points, right? One has to say, what's the price point? And then a negative test, yes, within 24 hours, but a positive test will require a repeat testing. If you don't want a repeat testing, then that price point of $5 would not work, but maybe $15 to $30 and that would not require repeat testing, but only using a pod-based, a pool-based approach. So this is really a conversation, but what we're saying is that we have this available right here in Memphis, and the menu of things are there, and what you can do logistically from your end as a clinic, as an institution, and then encourage others. Local restaurant you go to, tell them, hey, guys, I want the server to be tested every week. Let's encourage that behavior. I'll end with this, unless there are more questions, but look, 6 months ago, we were in a very different situation, right? We did not think that, or 8 months ago, shaking hands was a big deal, right? We didn't think about masking. We've changed our culture for distancing. We stay 6 feet apart. Anyone who's closer than 6 feet talking to me, and I feel very uncomfortable. We've changed our culture on masking, right? We all wear masks when we're outside. Jeff Warren said this, which is really telling. He said, you feel naked if you're not wearing a mask nowadays, right? I mean, it's just changed. We've changed our culture in distancing. We've changed our culture in masking to be safer. We're really talking about changing our culture in testing. We as medical professionals need to be doing that, setting an example for our community by doing regular testing. The price points are very reasonable. It's worth a Starbucks coffee once a week. Very reasonable, I think, for us to be able to do this.
One more question did come in. Is this testing model the same type of swab that we see at the drive-through clinics?
Yes, it's the drive-through clinics with the nasopharyngeal, not the anterior nares, not the deep nasopharyngeal. This is not the deep nasopharyngeal swabs, which used to be done, but now people are moving towards a simple. There have been plenty of studies that say just a simple nasal swab is 95% sensitive, and so it's as good as the nasopharyngeal swab or the mid-turbinate. So.
All right, I'm not seeing any more questions.
Okay.
Dr. Jain, Dr. Smalley, Jim Sweeney, thank you. Dr. Azar made some comments. Thank everybody. Appreciate everybody's time tonight. We'll get this recording out, and Dr. Jain, let us know what we can do to supplement the message to get it out there. We'll certainly put some stuff out in writing and social media and whatnot.
Okay, be safe, get your flu shot. Bye-bye, everyone.
Thank you. Good night, everybody.
Good night.